This is a monthly discussion into the evolution of healthcare security with me, Tony York, your host, and a few of my special friends. I invite you to join me in learning alongside some of the brightest minds in the security industry as each month we continue to take a deep dive into an important topic surrounding the safeness of healthcare. Whether you're brand new to healthcare security, a second careerist, recently promoted, or one of the old hands, I think you'll find these discussions insightful and, more importantly, useful. So let's get started. In today's program, the Roe versus Wade reversal has generated a lot of emotions, and that is something those of us serving and protecting healthcare need to remember and prepare for. Today's conversation, we're going to dive deep into the history of violence that has stemmed from such a heated issue and the impacts that can be foreseen on a healthcare security program. We hope to share an enlightened perspective on some evolved practices for how to monitor the threat environment, as well as discuss some important mitigations and those techniques that can help you to really understand how to have conversations with key stakeholders that go beyond just a threat of violence. My special guests this month are Kat Kemper, who is known to most in healthcare security as Kat. She is a thought leader and currently the vice chair of the IHSS Guidelines Council. With more than 22 years of experience in healthcare quality, risk, safety, and emergency preparedness, she's worked with over 18 years with HCA Healthcare, where she administers security programs at the local, divisional, and national level. She's in the final throes of completing her Ph.D. in organizational development and change, and she's placing tremendous emphasis on bringing evidence-based practices to the reduction of violence in healthcare. Welcome to the show, Kat.
Hi, thank you, Tony.
Joining Kat and me this afternoon is Robert Burns. Rob is the president of Paladin Risk Solutions, and beyond being an award-winning executive, he has extensive experience mitigating risk for organizations of all sizes and shapes. Rob was instrumental in helping the province of British Columbia assess and manage the serious threat of planned attacks and targeted violence to providers facilities in the 1990s and 2000s, when the healthcare community in BC faced some eerily similar issues as those we're starting to see today. Rob has agreed to share his intimate knowledge of that history so we can learn from his experience and how to apply those lessons learned in today's threat environment. Rob, welcome to the show.
Excellent. Thanks, Tony. Hi, Kat.
Hi.
Rob, let's start our conversation with you. You were initially engaged by the province of British Columbia after a major proponent of women's reproductive health and rights, Dr. Garson Romales, had two very frightening attempts on his life where he was wounded. The first attempt on his life is considered by many throughout Canada as one of the most violent anti-abortion crimes in Canada's history. In the aftermath, there were other threats and a lot of other personal security issues faced by several healthcare organizations and hospital executives. And I know you were intimately involved with many of them. Rob, can you just share some of your experiences and highlight some of the important lessons that stem from your involvement with therapeutic abortion and the history of violence to that issue?
Yeah, absolutely, Tony. Thanks. Maybe I'll start a little bit with Dr. Garson Romales, known as Gary Romales to many of the people. Dr. Romales did have some minor targeting of him, protests, for example, but nothing serious. He did not have any large death threats of any kind. November 8th, 1994, he was shot through the back window of his home, sliding glass door, actually, where he was eating breakfast, where he sat every morning and had his breakfast. His daughter and wife were at home at the time. It was a very real event. It was very chilling, and it was two shots fired from a high-powered rifle. For those of you who know firearms, it was a AK-47 7.62 round, and it was fired probably, my guesstimate would be, in memory, would be about 35 feet from where he was sitting. He was right next to the glass of the sliding door, and it was fired from underneath the fence, which backed onto a back alley. He had no indicators that this was going to happen. He had no indicators he was being targeted like that. That resulted in meetings being held by government, which I was invited to participate and asked to ultimately be the lead to head up the personal security reviews around personal safety and healthcare, specifically around therapeutic abortion. Providers, hospitals, clinics, staff, private offices, families, homes, everything. It ended up going on for years as it continued to be very problematic. So I was the first one back through the door with with Dr. Romalis when he got home, and he led me through those chilling events, showing me exactly where he was sitting and what happened once he was released from hospital. The gunfire ruptured his femoral artery. The first shot actually hit the chair as he leaned forward and spun him around and almost stood him up. And the second shot landed into his thigh as he was standing. And as you can all imagine, it was a very real event for the family, friends, people in healthcare in particular. Very trying time. Can't tell you enough about how much it rippled and affected so many people. I would say the ripple from that directly with people I dealt with over the years was in the hundreds, and from them and their families and the people where they worked went into the thousands. I think one of the biggest ripples I saw was just how many people didn't want to work in certain healthcare facilities or parts of a hospital or a surgical daycare or a clinic, and the pressure that these people suddenly found themselves under and the duress they were working in.
Rob, that was obviously a very scary time for that family. And I would imagine for other providers that were engaged and knew Dr. Romalis as well. What impacts did it have on others that were around him, that were a part of his community itself, and how the issue of that targeted violence impacted them in addition to he and his family?
I was surprised actually at what the impact was, because when I found that when it's a group against group event, it becomes very trying. Although that was very targeted on him, it was very much one group against another, and one group feeling they were losing a battle, which seemed to eradicate and change protesters to activists, to extremists before our eyes. So the thing I found most alarming is that after that event, live rounds of ammunition would be found on other people's cars. Protests grew, problems grew, threats grew, suspicious packages, bomb threats, everything grew. Protesting at physicians' homes started to happen and increase. Instead of people seeing that event as horrific and over the top, that actually lit a fire for many people. So it did affect, Tony, a lot of people. I saw, having met, many hospital administrators, lawyers, government lawyers, healthcare workers at every level, from janitorial services to physicians to nurses to anybody who may work in a facility, and in particular clients. After that event, I saw clients trying to come and go from healthcare clinics and hospitals be chased to their car, be swore at, have their picture taken and told they'd be identified publicly for what they're doing and coming and going. It was a very big ripple effect. I saw families struggle with alcoholism, teenage runaways as a result of some of these things that were happening, because the threat was coming from the outside of the building for the most part. Not that there isn't, often an internal threat, but the ripple effect was absolutely enormous.
It's amazing to hear you share that, and you start thinking about what most of us in healthcare security see as our primary charge, which is really the threat that's involved with the people that we invite in. The issue of violence in healthcare has been spoken about a lot, and I'm sure we'll talk about it even more over the course of time in this series. But you're also chatting about with us how the security risks now extend beyond the hospital or any of our properties, particularly, and go inside the home. And Rob, any advice that you would share with this audience about how that evolved for you? I mean, when you were dealing with this, especially in the 90s and early 2000s, obviously there was some different approaches, different mitigations. A lot of technology has changed. But I'm just curious, as you start thinking about how the protection of an individual stems inside the home, any advice that you might want to provide to the audience itself about how that has changed, especially for the healthcare security practitioner?
I think I'll just start out with the targeting piece really quickly. One of the things that became really apparent is that people could be targeted for a variety of reasons, not so specific as maybe Dr. Romalis, for example. So what would happen is protecting their privacy became the forerunner to protecting their security and their personal security and their safety. A lot of people started to realize they were going to take risks coming to work, but they didn't want those risks to go home with them. And so it was actually the external environment where the risks really came to light. And then, as you've heard me use this term before, predictable places and predictable times. So amping up security at predictable places and predictable times became highly important. One of the biggest measures that we used, because we often didn't know who a perpetrator was, in the sniper attacks, which there were 3 in Canada over a period of 4 years, from 94 to 97, 3 different provinces, very similar, all believed to have been done by the same person who was eventually charged and convicted in the United States for the shooting of Dr. Slepian. Those became very chilling events because it was ongoing and it didn't get resolved. So the ripple from that also creates a lot of concern. So the type of targeting that would take place would stem to vehicles, would stem to transportation, would stem to coming and going from home, leaving home at a predictable time and place, and arriving, coming, going. All those pieces needed to be addressed differently. And the one thing, I can go over this a little bit later, I know it's a direction we want to go, talking about the steps of a planned attack, but those first 2 steps are locating and identifying an individual. And when you're dealing with professionals or employed persons at predictable places and predictable times, it's pretty hard to hide them. And this is why, and I know Kat can speak to this at length, but this is why when people are have violence in the workplace, it's such a chilling event for them. The person knows about them. They know when they come and go. They know where they park. They know what they drive. They may even know who their family is and where they live. And that was the case in this scenario. And that led to some very stressful times for people who were targeted and found themselves being named. There was an awful lot more. I'd say 90% more activity was going on in the background that I was aware of and working on than was making into the public media.
That's a scary thought process, Rob, when you start really contemplating, and for a lot of the American audiences, when you're talking about the shootings, that was a very rare circumstance for Canada. It was at the time, and I think we would probably say it's still very similar today. But Kat, if I could turn my attention over to you. You published a wonderful article in July. You called it Increased Healthcare Security Risk Due to Roe versus Wade Reversal. Talk to us a little bit about what inspired you to write that article.
Yeah, thank you, Tony. So earlier this year, as part of my academics, I was doing some research on systems and systems approaches, and specifically the downstream impacts due to public, social, or organizational changes. As Robert was saying, the ripple effects. And I thought this would be a great topic. It was hitting the media at this point in time to highlight the impact of Roe v. Wade, the impacts to numerous systems, and to identify areas that the healthcare facility should prepare for. So I've highlighted a few in the article, such as, the influx of infants and maternal population, safe havens, mental health, child protective services, shaken baby syndrome, and numerous others. But those, there is such a huge impact of systems just for one decision.
It's to put a plug in for your article. For those who haven't had a chance to read it, I know Security Magazine was the original publishing house, but you also were able to put that on your LinkedIn page, which is available for anybody who wants to follow you there. And I think it's a great read for those who have concerns about it. But you also listed out a few impacts that you predict that this overturn may have on a healthcare facility specifically. Was there any one or two that gave you the greatest pause for concern, Kat, that you'd want to just share a little bit more about with the audience?
I think the 7 that I highlighted are really important. There's many more, but I think the trend in the 7 that I did highlight, there's obviously a huge internal risk increase happening at healthcare facilities, whether it's a clinic or a hospital. The high-risk populations has the potential to increase, whether that's infant or mother or mental health, or even having CPS or child protective services or internal reporting issues happening, and how security has to interact with different agencies and different populations. And then from an emergency preparedness, I think those are the 2. So increased risk with internal threats, and then emergency preparedness with the influx of the population that you may not be ready for with increase in births, but also with the protesters and the external threats. Those are the main concerns I have.
And I think you said it best. I mean, they're all something that we have to take into consideration, especially when we're looking and assessing the risk facing our individual facilities. You also talked a little bit about the risk don't necessarily fall solely on the anti-abortion extremist. You referred to in your article about there are some other local groups that could be of concern, and we start thinking about these external threats. I mean, how would you advise the healthcare security professionals that are listening to us right now about what groups, what other areas could this threat stem from? Who should we be concerned about?
Sure. In some of the research I found, it's not just the extremists, whether it's the far right or far left, but also there's churches, there's individuals that have a strong stance against, either one side or another, that basically can get the public or the social piece of it stirred up. And so really, it's not the extremists in all stances, although it could be. They're the ones that tend to gather large gatherings. But it could be one person or two people holding up signs that are local in the facility around the area, and they could just start this wave of communications that people just feel strongly about, and they join in.
I appreciate that, and I think that's a mentality that I think we all have to realize, that threat is not just going to come from one sole place. It could come from a number of different, and Rob, you alluded to it earlier. It's got the copycat effect that can just sort of boil over and create its own little ecosystem in its own right.
Can I jump in? I just want to add
Please.
to what Kat said. Totally agree. And, I know Kat and I've spoken about this before too. And, just as an example, when we first saw sort of more radicalized version of protesting going on, when I say that, I mean aggressive, threatening, police constantly called arrests. We tried to identify key players. Now I'm going back into the mid and late 90s who were attending certain protests, and some of them were just hanging around in the background. We ended up finding the head of the Ku Klux Klan from Canada, from Saskatchewan, who was present in Vancouver, meeting and standing with the head of the Aryan Nation skinhead movement in British Columbia at the time. And the people they were meeting with was the church group that was supporting the protest, primarily elderly women, who were also fundraising and supporting everything that was going on. And whether they knew who they had in their midst was hard to tell, but there was a friendly atmosphere amongst them all as far as collaborating on what they were doing. And then we identified some real key players, to Kat's point, that were local, that were turned out to be very dangerous, that had a history of violence, that were a part of these protests and part of other types of groups and protests as well, that lent themselves to this, and to the point where I was followed from my own office by one of them. They were very, very aggressive and assertive, and it was a very mixed bag. It wasn't just one group specific, and the fact that they would, and again, Kat can speak to this better than me, but the fact that these people would collaborate was fascinating. And when we realized who we had there.
I completely agree. And what I found interesting was you could go onto the internet and you can research the different groups that are out there that will go and protest the abortion or pro-life choices. And as you mentioned, Ku Klux Klan, Aryan Nation, there are many of them. I wrote down a few: Lambs of Christ, the Missionaries of the Preborn, American Made Patriots, Army of God, Operation Rescue. There's Jane's Revenge, Proud Boys. And, there's also what they call the lone wolf terrorists. You have reverends, you have several reverends out there and other individuals that are very well known. So I would encourage security to go out there and look and see if they have any of those individuals or groups of individuals around their area, because they have a greater chance to gather if they are not only local, they have groups local, but if you start hearing about different gangs or group activities, you're more likely to see something happening there.
Yeah, it's interesting, and it sort of falls in a trend that you alluded to in your article, and I thought was worth noting to the audience is that in 2021 we really saw a significant increase in the volume of stalking events, the blockades themselves that were happening, the suspicious packages or the hoax devices that were found. It was really interesting, and I think it stays very true to what you've just alluded to. So, I mean, the threat actors themselves are causing concern, and I think these concerns are very real. But Rob, when we start thinking about today's threat environment and taking away those lessons of our past, walk us through from your perspective. I mean, you've been in the intelligence game for a good amount of time. I'm not going to try to say you're long in the tooth by any chance, Rob, but I think experience has been a wonderful teacher. But talk to us a little bit about tools, mitigations that are now available to us as security professionals that really can help us combat targeted violence, because that's really at the end of the day what we're talking about: targeted issues, targeted violence, and the concerns related.
Well, I'll just start by a very brief history of a planned attack. So we can go back 1,000 years. And the methodology is still the same. Stabbing the emperor on the stairs still works. The Trojan horse still works. All these different events still work. So when it comes to physical, actual attacks, the methodology hasn't changed. What has changed is the delivery system and the technology. Where we used to walk, ride a horse, catch a ride, eventually a train, and then behead cars, and on, changed how we did things, or how people did things, how perpetrators did things, how an aggressor acts and behaves, but the methodology is still the same. So the tools that we have now, just in my career, are so far superior. The ability, as Kat mentioned, to be able to do research on the internet, for example, and understand the history of what's taken place in a matter of hours, rather than having to have lived it for a decade. The ability to identify activists and groups and what they're saying. Now, they may not be responsible for being an all-out aggressor or a violent attacker, but there's at least hints and understandings of what's going on. And being able to know what the past history was and what's present usually paints a good picture for the future. So for us, for example, we have a system called Blue Sky. We're actually able to monitor live events as they're unfolding in just any geographic location we choose. And so that is a huge breakthrough that never existed before. So to be able to monitor online for all kinds of information, we use that for any hazard approach, but threat in particular, it allows us to see what's happening. So we can look at what's happening in the past. We can look at what's currently happening present. We can do open source intelligence. We can have some research, but when we can also monitor for a live event and see what's taking place and what kind of emotions are bubbling through. It's an absolutely incredible set of new tools that's now available for security practitioners that was never there before.
Well, it allows us to be a little more proactive instead of just reactive, right? We can hear what's being stated out there in the community. And I think Uvalde and so many other events have helped us see, although a different circumstance, but a lot of our threat actors are communicating their intentions. They are bringing awareness to what they plan to do, which in so many ways, the ability to monitor that, whether that's through a geofencing or by an organizational name or an individual's name, I think is a phenomenal tool to have in our disposal, which it sort of reminds me of the advantages that we get now when we're doing after the fact investigation. I was having a conversation recently about what it was like to actually go reel to reel on video versus actually having a IP-based camera system that can allow us to actually scan and do what used to take us 8 hours and do it in a matter of minutes now. And I feel like it's given us the gift of time, and that's exactly what this intelligence gathering tools that you're alluding to, I believe, are creating for us as well. And I think we're still learning how to harness those in the healthcare security arena. I don't think we have fully grasped exactly. Any advice on that front, Rob, that you would say is if you're a healthcare security professional trying to manage the assets, the people, the patients, the staff, anything you would say along that front that you think would be of great use to this audience?
Well, I'll just touch back on where we started from there with, excuse me, with the online monitoring. So one of the things we're watching for there is obviously an escalation of situation. But one of the things not to be fooled by is that when, especially group on group issues, when crowds get slower, then you start to see more of a desperation come out from, and more of a radicalized group. So people will say, well, 1,000 people showed up a year ago and now we get 10 people showing up. And it doesn't necessarily mean those 10 I'm not talking about. I'm just talking about if you're monitoring that, rather than thinking it's dissipating, it actually could be getting much more serious on a radicalized level. So it's kind of opposite of what you might think. But we're looking at the escalation of events and the amount of events and the frequency of events, but also the severity of what's taking place at those events. And that, like I say, could also be shrinking, but that could also be an indicator. So you get signs of desperation within groups and signs of subversion. So you have key players who suddenly disappear off the map that were very, very vocal before, and now nobody knows what they're up to or where they are. So those are key pieces. When it comes to understanding, more about what's taking place, it's those early warning indicators that we really relied on. I'll just touch on them quickly. We created a reporting system because everybody wasn't reporting what they were seeing. So a daily reporting system of any activity being seen anywhere. So we were gathering North America wide, but I was primarily focused on what was taking place in British Columbia. But it was clear that this was coming from afar. It wasn't necessarily local. It could be, but it wasn't necessarily the case. An education system and training to give staff an understanding. It was huge. Give them some feeling of empowerment. The best surveillance system was the people coming and going from outside saying there's a same strange vehicle parked there again. I've got a description. Then finding out that that same vehicle was, literally 500 miles away the day before at another location, literally, and had been reported. So an early warning indicators that were being monitored, good education, awareness training, letting people know about shared experiences, not being afraid to share what's happening elsewhere, because where it was happening anywhere else in North America could happen there. It wasn't specific just to to a geographic location or one group in one specific area. Those early warning indicators, some of them, when it came down to the very close, tight stuff, Tony, I've had people laugh at times, but I've used them throughout my career from what we learned from this. It resulted in writing some of the original material on planned attacks and targeted violence for British Columbia because we learned so much about it. And I know these still sound silly to some people, but that's okay. But signs are being followed, obviously, are stalked. I went to people's homes who said, put the lighting in, it doesn't work, to find the bulbs were unscrewed, to put surveillance in the location and find someone showing up at night and coming into the property and up onto the door and trying doors on the house from in darkness. So as silly as it sounds, is there been signs of tampering? Is there signs of boundary breaking or boundary testing? People who show up to see if anything's going to be enforced. Signs of testing security, setting doors and alarms off, breaking lights to see if they get fixed. All those things are early warning indicators. And then when it came really personal at home, like I mentioned, light bulbs being unscrewed, dogs being fed. I'm aware of other issues with pets being targeted as well to get them out of the way. So have they been fed? Are they now approachable by someone who's been feeding them, or could someone now hand feed them some poison? We saw everything you can possibly imagine. Glue in door locks, to delay people when they got to a car so that they could be fastly approached. So the distance from one secure location to another, I hate to use this term, it's an old term, it's called a kill zone, but leaving one secure location to get into another, leaving the vehicle to get into a building, the distance that takes, and then when you arrive, finding the doors is you can't get in suddenly was terrorizing for people, and then they were quickly approached or threatened. coming back out and finding terrorizing items left. Like I mentioned, live ammunition on cars was chilling after a shooting. So those became terror type tactics. I can go deeper into that after if you want as well.
Yeah, and you know, Rob, it's amazing just how real and how scary some of these examples, and having been in some conversations with you, having some really important educational dialogue with especially executives that are really present in social media, and even other medical providers that, you know, are a little bit more stand out. They are expressing their views and using these various platforms. But you bring up something I think is critical to what we like to refer to in the security space as a force multiplier, and that is that power of education. And, you know, it is interesting to see how, you know, it wasn't that many years ago that healthcare executives really didn't talk a lot about executive protection. We didn't talk about how they could be the target of violence. It was usually having conversations about others on their team and others in their staff, and how it was impacting them. And I think we're starting to see this trend. I know IHSS wrote an executive protection guideline and introduced that here just in this calendar year, and I think it's just amazing how we're now starting to lever on the power of education with these individuals. And Kat, I think it's important that we think about, you know, that's just one consideration in the security arena. Any other considerations, any other safety, security implementations that we should be thinking about, whether they're people or process or technology, that the healthcare facility could deploy to really help them successfully combat targeted violence?
Yeah, thanks, Tony. I agree with Robert. There's early indicator warning signs and they're testing the waters, but really, you know, paying attention, looking at those risk assessments, looking at them from multiple different views. So not just active shooter, but also civil unrest and the VIPs, et cetera. Looking at the environmental aspects of it, the job roles, who's more at risk internally and externally, just from maybe their scrubs, their uniform, what their badge says, who's at risk for more targeted violence than others. I think, you know, utilizing technology and the AI that it could perform will help, as well as the social media aspect of monitoring real-time events and threats. So I would say, you know, I always go, you know, start with the low-hanging fruit, no cost, low cost things. It's really no cost to do a risk assessment. It's really no cost to do education and training, to hand out flyers. Start there. You get a huge bang for your buck, and then you can really go into the technology pieces and the things that cost money. But really, what we're saying is, while everybody's at risk for, you know, potential civil unrest or you know, threats, really look to see who's really at risk for some of the events that have happened, the shootings and the threats. It's physicians, the clinics. If you have a clinic on your office or a medical office building, we just saw St. Francis earlier this year. Look at not just the hospital, but look at all your other areas where there could be potential threats. Look on your internet to see. I was doing some scans of hospitals and I saw some clinics popping up on the hospital property on a map. I don't know if you're aware that that's happening. So look at, and even your paper maps that you're handing out to patients. Look at everything, do a real risk assessment, and then figure out what your risks are, your threats, and how to mitigate those.
You know, Kat, it's interesting as you think about your conversation. Oftentimes, hospitals, especially in the U.S., will have medical office buildings that they may actually own the physical land that those buildings are owned, but they're being managed by a different entity and can have services embedded with that that may not be in scope for the security team, but actually the risk and the threats themselves are. And I think it's important that we not just limit ourselves to the owned assets of the hospital or the health system that we may be working for. I think you're bringing up a fantastic point just to contemplate hey, we may not be doing it as a part of our organization, but some services could be offered without our awareness if we're not scratching pretty deep into it.
Yeah, or even physicians credentialed. They may not necessarily work at the hospital all the time, but they may be credentialed there, and
Yes.
somehow it gets picked up, and now it's part of the hospital. So even though they're not working there full time or even part time, they have credentials there, they could be targeted.
And targeted sometimes. Rob, I'm sorry, I think you were going to add some commentaries, please.
I was just going to jump in and stress what Kat's saying, that someone who's really at risk, that's identified, will often be somebody also that will say they're willing to make a stand, and they're willing to take these risks, and they understand those risks and they'll take them. But what they do is they bring that risk with them. They bring it to work and they bring it to home. So all of a sudden you have somebody, that you're the janitor and you're going from a clinic or a hospital setting, but now you're at risk because you're working next to this person. So there's some other things to be considered here as well when you start to look at the heightened level of risks and how they're going to be managed. Because what also happens when it comes to targeting is people will, if they can't get at the highest risk person that they want, they move to the secondary or the third. I'm very confident in the shootings in Canada that those were looked at, multiple targets were looked at as an opportunity to aggress upon or shoot. Those weren't just the 3 individuals picked out. Dr. Romales may have been the first one shot, but I do not believe for a minute he was the only one who was looked at to do that. There was an opportunity after they went through the steps and reviewed who was vulnerable and how they were vulnerable and how they would execute a planned attack, that he was chosen.
Well, let's talk about that. I mean, obviously there are steps, and you've alluded to us here in this conversation of some of those steps. Are there typical steps that are followed when a planned attack? I mean, obviously they may change their focal point, but walk us through a little bit about that. I love the term you used earlier, most predictable place, most predictable time. And I'm assuming there's a lot of other educational nuggets we can maybe just chat about here this afternoon.
Sure. When we do a violence risk assessment, we often know who the perpetrator is, or we have a lot of information who that perpetrator might be. In a situation like this, you don't. You just know that there's potential for an attack. So unlike a violence risk assessment, which I'm very work with all the time, when you have a group on group, we don't necessarily know. We may, but we don't necessarily know who's going to be targeted, and we don't necessarily know exactly who's going to be the aggressor. So the steps of a planned attack typically unfold before you, and whether they can be spotted or not is a whole other challenge. The first two are locate and identify the right target, or a target. The third step is then becomes planning, and planning then has many steps depending on what kind of event they're planning, obviously. But those steps are consistent throughout history. That's what we've found. So in that planning phase is usually some first person contact, first person attendance, boundary testing, someone having a closer look. And often it becomes a smaller group at that point because everybody doesn't want to know what's going on. So you could involve others if you're trying to locate a doctor or you wanted to protest at, or locate the vulnerabilities of a clinic, or you protested there before, so you have knowledge of that location and you could plan from that knowledge. So the first two steps in this particular scenario that we're talking about today are very, very fast and easily achieved. It's the planning phase where you still have to try and interrupt it. When you look at, I've testified on protection of witnesses, for example, and when you look at witness protection, the first thing you do is move the person into a secret location. If you look at police methodology on it, and often change their name, and or at least mask their identity and move them so they just can't be found. In this type of scenario, you can't do that. So these first two stages are very quickly identified, where the physician has an office, where their staff has an office, where the clinic is inside a hospital, where a freestanding clinic is. All those things are very, very easily achieved. So the planning phase becomes stalking, surveillance, and simple things like the garbage gets stolen. Somebody makes incoming phone calls and asks questions. Somebody shows up at a door and does something. Neighbor spots something unusual. Those are all really big early warning indicators. and without that a chance to interrupt those activities and spot them, then it can continue on. The minute it's spotted and interrupted, the minute you can't follow through with those first 3 steps, you will not have a successful attack.
I think
Rob,
Tony, sorry, to go back, I know we're talking a lot about external threats, but also we have those threats coming inside. They may be patients, they may be employees. And then going back, we have Child Protective Services coming inside. And so a lot of our facilities and clinics and buildings are public. While they may be private buildings, it's open to the public and they can come inside. And so being aware of individuals inside your buildings also is very important, and the threats that happen inside.
And it's amazing how healthcare has evolved, and we're at an interesting time inside of healthcare security. As most of us thought we were never going to have true visitor management, and the level of controls that we saw be instigated and instituted, frankly, right in the beginning of COVID. But now that we're starting to look at it as a post-pandemic moment, we're starting to see a lot of folks starting to reopen and go into their pre-pandemic approaches. And I say that because I think one of the best things that we were able to see happen in the midst of all that is that we could actually show we can have a lot more control of the environment. And there was an ability to really do exactly what you said, Kat, is have a better understanding of who is inside of our organization, unlike any time in my 30 years previous. And I think it's important that we realize that. But as we think about the term, Rob, I've heard you use in a lot of our executive protection conversations, and you've been very instrumental, and I can't say thanks enough for what you've done in the past, just helping some of the executives we've talked to just really grasp some of the concerns and the issue. But I heard you use in the past the term bubble zone. And I just wanted you to talk about that with the group, and what does that really mean? Because I think those are the implications. You've used a ripple effect here today, but I think it's important our audience just hears you talk about that bubble zone, because I think that's got a lot of implications for all of us in this space.
The bubble zone is actually a legal term that was invented in the 90s here after the shooting. Once we identified, and it went on for years, once we identified how the threats were being perpetrated and were able to prove how a planned attack unfolds and the struggles for people trying to work at facilities and to, in particular, clients come and go unemotionally molested in any way and safely come and go. Just using a hospital as an example, somebody could be arriving for a completely different reason for a surgical daycare, was being accosted and had photographed, outside of a facility. As a result of that, working with the provincial lawyers in British Columbia, we gathered the information and intelligence around creating bubble zones. And the bubble zone became a legal distance around the outside of a premise that nobody could protest within. Now, I am a big proponent of legal protest. I believe in protesting. I believe in a free society. I'm very much appreciate protests. I think they raise the right attention, but I don't like violent protests. And I don't like the violence that could stem from, the wrong kind of protest. So we need them in our society, but what was decided was, and I found this in every case, is safety always trumps people's personal privacy. It's the reason why some cities have cameras. If it can be proven that there's no interruption in a protest, that it can be across the street and be just as effective as a protest, then why does it need to be in the front of the doors, chained to doors, blocking access, screaming at people at close range? So what could also happen is people could arrive and park and come inside a bubble zone. So bubble zones were created around the facilities, but they were also extended to homes if they needed to be. And then yes, you do have a legal right to protest out on the street, but you don't have a legal right to protest and block access to people and control an emotional zone that people might have to travel through and create fear inside of those. And that's really where it was stemmed from.
So if somebody is legitimately and legally protesting, obviously there's some security risk associated with that. Any guiding principles, and this is a question for both of you, any guiding principles that you would share for the healthcare security professionals that are listening to us right now? Things that they ought to be aware of, things to sort of keep in the back of their mind as it relates to the concerns, the risk, as well as the legal authority that someone has to protest.
I'll let you go first, Kat.
Thanks. From what I've seen in, for example, union protests, our security had seemed confused as to what was our property line, as you mentioned, what's the bubble zone, what truly is that zone, and where can they stand, where can they not stand, can they impact visitors, can they interact with them or patients. And so really understanding what security's role is with protesters or individuals that are standing outside of the property lines, knowing where those property lines are, what they can do, what administration supports them in doing versus what they can and cannot do with law enforcement. I think it was very eye-opening as to what was actually occurring with what administration was okay with them doing. And so knowing that stance, the protocols, operating procedures, I think is important from a healthcare standpoint. Robert?
I'm going to give you an example of protests gone bad. And that's why I think they're extremely important to monitor, watch for signs of increased activity, de-escalation, thinning the group, who's more hardcore, all those things. The second attack that happened to Dr. Romales here, because he survived that first attack, as we talked about, was 6 years later, summer of 2000, arriving at his office and arriving at a predictable place at a predictable time. And I'm just going to go back 1 hour. At noon that same day, there was a group who protested daily at a women's healthcare center in Vancouver. And 3 men were present at that protest. And it had gone so far that a group of women who protested all the time bought the house next door so they could be inside of a bubble zone area legally and be in their own front yard to continually challenge anybody coming in and out. And so they literally bought the house next door. These 3 men were present in the front yard, and as a result of some activity that they were involved in, the police were called and checked them, but didn't check them fully, just moved them on their way because they were coming inside of a bubble zone and needed to move on. They were very upset, and an hour later, Dr. Romales was stabbed in the back when he arrived at his office at 1 p.m. Can I say for sure that it was one of those 3 men? Of course not, but the implication was very clear to everybody involved that it was, and it immediately went back to the police to see what they could identify and see. There was a clear description match between the 2, but that person has never been caught.
Obviously, what it's saying is that the threat actors are becoming more and more sophisticated and should not be taken lightly in any way. And I think as all of us in healthcare security are starting to face the potential for these kind of events, we have to be worried for those that we're bound to protect and to serve. And I wanted to just do a time check here for the audience, and if folks have questions for Kat and Rob, feel free to go ahead and start loading those into the chat feature. Be happy to bring those in. But I wanted to switch into an article I read last week, and I shared it with both Rob and Kat. And it was titled "Tensions High During Demonstrations Outside of Boston Children's." In short, there was 2 groups of demonstrators. So this wasn't one group, it was actually 2 on the opposing side of an issue, and that was a hostile face-off outside of Boston Children's Hospital. And the facility had received a number of threats over the last month due to a new service, the transgender health services that they were offering. Robert, I know you shared with me from a prevention standpoint that you think you're going to see the return of the bomb threat. And Kat, you sort of alluded to the copycatter as well earlier, and the similar tactics that basically raise awareness to a cause, disrupt activity. It could just cause fear with just a simple phone call. Robert, maybe just give me a couple insights, if you would, in the audience about, hey, what do you feel like is getting ready to happen in the threat environment and the impact that a copycat's behaviors could have on our security programs?
Sure. So I alluded earlier to terrorist type tactics, and I know that sounds extreme, but so what happens is what's been successful in the past, and then when you have a major event that somebody, as you would call them, a threat actor evolves from. So let's just say one bomb goes off. Now, every time there's a bomb threat after that, it becomes extremely serious. If it's nothing but always hoaxes, then we know that, it can be disruptive, cause challenges and everything. But when we have an event, so using the shooting, that we were talking about earlier, that's a good example where once we have a shooting like that, the next day, doctors were threatened to be shot, specifically, right after someone they knew was gunned down at home. After the stabbing, the same thing happened. A doctor was identified the next day saying, "You're next." So very chilling. Now, was it the same person doing that? Maybe not. It may have just been somebody spreading that fear. So that's the way I feel about, return of the bomb threat, I think is the term I used last week when we were talking about something else. Yeah. And it's just effective way of disruption, just exactly what you said, Tony. Create some fear. If heaven forbid there is some kind of major event of any kind, it plays in the fear of everybody. You suddenly have people who don't want to come to work, who don't want to work in certain environments, don't want to work with certain people, don't feel the workplace is secure enough, depending on what the threat is. And you only need to have those kind of threats. I would draw a parallel to active shooter. For those of us who've been in the industry over 20 years, know there was no such term 20 years ago. There was events, but not like we're seeing now. And when you start seeing that at school, now we had an incident here a couple of months ago in British Columbia, in a city where it suddenly was reported that I think we have an active shooter at an elementary school, and the panic that went and set in, and it actually was not an active shooter at an elementary school, but the immediate panic because of the success, for lack of a terrible word to use, the word success, but the success of the fear and interruption and primal feelings that people can't refrain of children being shot. The very thought of that had parents racing home from work to get to a school, and who could blame them? So when you have an event like that take place, like a shooting, like a bombing, so if there's any kind of escalation, then we're going to see the return of the similar threats in a terrorist type tactic be successful.
Yeah, you're flooding my memories, having supported a lot of hospitals in the wake of Columbine back in the late 90s. And I'll never forget the fear in the parents' eyes and everything that it caused. Not to mention everything else that was happening in the aftermath of that tragic event. Kat, I'm going to switch gears with you. You're obviously been a very active and contributing member to the IHSS Guidelines Council, and serving as their vice chair now. As we think about closing up our time with the audience today, any industry-specific resources that you think are available that our audience should be aware of and should have in their arsenal as they think about combating targeted violence?
Yeah, there's definitely a few that we've created over the years and updated recently. There's the Targeted Violence Guidelines, the Threat Management Guideline, Executive Protection or the High Profile Individuals Guideline, and even the Security Vulnerability Assessments Guideline. So we continue to develop more and more as we see areas not covered or new emerging threats that are happening. But definitely those are some. We also have the Workplace Violence Toolkit that has some guidelines within that reflects on practices that viewers should look at if they haven't already. And the design guidelines also, how to harden the environment.
I think I agree wholeheartedly. I think thinking about the built environment itself can not only save a lot in the operational cost of managing and running a security program, but we can do a lot to harden the target and really do some things to be thoughtful, not only where placement of cameras and access control devices go, but the flow of traffic, where we actually have controls for visitors and patients, and where we want to have, using the old Disney's term, what's off stage and what's on stage, right?
Absolutely.
So I've got a question coming in. What physical and practical security measures have you found work best to keep facility and individual care providers safe? Rob, you want to tackle that one first, and Kat, I'll turn to you on that one.
Sure, I'll give you a simple one that worked really well. We were seeing the pressure of hospitals and clinics to increase security, lock things down, and then the posing issue of that was, of course, saying this needs to be wide open. We need to be able to greet people. We need this to be a comfortable environment. And there was a couple of places I came and went and I watched how it was working, and I'm going to use an old-fashioned term, so I apologize, but it was called a man trap. And basically you had to go up to the camera, show some ID, and be let in through the first door. And then when it closed, they let you in through the second door. So the question always was risen when I get inside by the people operating that, front end staff, what decision do you make about opening the second door? Like, at what point did you decide that you would or wouldn't open the second door? Well, if they were nuts in there, they started screaming, we could see they have a gun or anything. I said, do you think once you let them in the first door, they were going to do that and not get through the second door? So really, if you're opening the first door, was it a pretty clear sign you always open the second door? Well, yes. So it wasn't really effective. So very quickly, what we decided to do is turn the whole waiting room into a man trap. We made a secure facility start really at the first door, and then secondly at the access door into the offices, and literally made the Lexan, ballistic resistant, made it all look nice, made sure nothing in the waiting area, because the whole waiting area was now a man trap, and nothing in the waiting area could be used as a weapon. It was all soft or screwed down, couldn't be moved, was attractive, there was nice artwork, all those things. It was very inviting, but so someone got in the first door and now they were in view of cameras, people monitored, and then had to prove themselves to get into an appointment. And so that was a shift, and it got away from that ugly, cold feel of almost like a prison man trap system getting in. There's just one example.
Yeah, it's interesting how most hospital leaders that I interface with, the one thing they don't want us to do is create a security state, or at least the perception of. They want good security protocols, they want good security measures, but they want them to blend into the environment and be attractive, be part of the aesthetics. And it does take a lot of balancing for us, especially with our design planners and the architects. But I think you brought up a great point about, hey, how can we do that? But it's blended into the design. It's not something we're communicating. We're not advertising that that's what it is. But it is a wonderful psychological deterrent in addition to the real deterrence that it provides. Kat, would you want to take a stab at such a good question?
Yeah, I completely agree with both of you. I think crime prevention through environmental design has to be first and foremost in security's mindset when they're working with the architects, designers, and blending it in to make the aesthetics look pleasing. I always look from an emergency preparedness stance. You work from your outer barriers to the inside, protecting the most inner sanctum of the facility. So starting with signage, alerting people, and then going, as Robert was saying, protecting your doors. That's, the front entryways in. So I fully support access control and walk-through metal detectors, securing the doors like we did with COVID. I understand that the public needs to come in, but let's really design the parking structures and whatnot so that the public can come in through certain doors. We could have a higher screening of those individuals. Also with employees coming through doors, they're also, if you look at any of the active shooters or violent incidents happening in the past decade, we have coworker on coworker as well. And so monitoring coworkers coming through and what they have. So securing the perimeter of the building and then putting additional levels coming in to each area, such as your access control, who has authority to enter certain areas that are more restricted, such as your ICU and EDs. It shouldn't be open access for all employees. They don't all need to be in there. Think of your medical records and who has a right to access to those records. It's the same should be for physical security. So I'm definitely a proponent of metal detectors and access control to secure the buildings.
And I think you're talking about a future trend that is probably going to see healthcare deploying more and more, and that is metal screening, but probably a topic for a future discussion as we get into the trends that are impacting healthcare and the safeness of them. Kat, Robert, I can't say thank you enough for taking the time today to spend with me, spend with this audience. Your insights, your perspective, my have mercy, have you offered a lot of food for thought, and your insights are just invaluable to helping those of us in healthcare understand the real risk of targeted violence. We have to manage them. We can't just stick our head in the sand. But I think we're also dealing with some, well, I would have said unprecedented, Robert, until you shared with us that, you know what, the lessons of the past are something that we can leverage for our future. But thanks again for joining us. It's been fantastic. For those of you in the audience, we have a survey. We'd love you to complete it, share what you liked and maybe what you would have liked to learn a little bit more about, or something that you would have liked us to maybe shy away from. But let us know what topics you'd also like to learn about more in the future. I'm going to say stay safe, stay diligent, stay aware, and I look forward to seeing you next month when I'm going to be joined by Tom Smith, President of Healthcare Security Consultants. And we're going to dive into the deep end about conducting that security vulnerability assessment that Kat was alluding to, and a lot of lessons that Tom and I have learned along the way when we're performing that important service. So with that being said, thank you all. Take care.
Thank you.
Thank you.
Bye.